In the next 20 minutes, I would like to convince you to be advocates for something that only you will be able to change at your hospitals. It's about the idea of using anesthetic when you routinely start IVs. Have you had an IV started, any of you? Kind of unpleasant. You know, you kind of grin and bear it because they can't see your face because they're too busy doing this thing. And have you had any operations where the anesthetist used a little xylocaine first? That's, you know, they do that. They do that. But it's unique to them in their departments. It's not something that goes across the hospital. My wife had a couple hips replaced, wore out prematurely, under warranty too. And they, in the ICU, where the preoperative thing, add a little bee sting of lidocaine, start the IV. Because if you miss, you could put it in another place, it won't hurt kind of thing. But in the emergency department where we work, we start these things all the time, and there's a lot of resistance to this. And so you are the only ones who will change this. And the nurses will not do this without your pressure. This first study here says one of the reasons, every one of you has probably seen a kid who's come in, and when the doctor walks in with the white coat or whatever, they freak. They freak. They've had many, many bad experiences. Or maybe they just overreacted, you know, maybe another kid would not have freaked. But anyway, this kid is now psychologically a mess when they interact with physicians. And this is a great paper, number one, to kind of make it clear that when people get painful stimuli over and over and over again, they become very fearful of the next one. And this is neonates, little tiny little babies who are born to mothers or diabetic mothers, who they keep on sticking their heel, doing blood sugars in these neonates. There are 21 of these neonates, and they compared them, who had gotten multiple sticks, with neonates who really had not gotten any sticks, and they were going to do venipuncture in them. And they videotaped these 21 and 21 neonates. And they had these previously validated scales for anxiety and whatever, pain, you know, et cetera, et cetera. And as soon as they wiped the alcohol wipe on the neonates that had been stuck multiple times, you could see the difference in the response to these kids, because they knew what was coming, kind of thing. They were very fearful, and basically showed that in this paper that negative effects of multiple painful procedures on subsequent experiences of pain and anxiety, those kinds of things. So a lot of places, when little kids have elective surgery, the first thing they do is slap on some of that EMLA cream on your dorsum of your wrists while you're going to be registered, and by the time they ultimately start the IV, that stuff's been on there an hour. I remember one of my little kids, when they're not so little anymore, went for a little surgery, kind of elective kind of thing. They ask you whether you have allergies about 20 times before, you know, everybody's got, you think it was the most important thing in the world, but there's lots of time that goes by. They give you that, start the IV, little kid's happy, no anxiety, no pain, no kind of thing. You miss it on that one, you start it on that one. Yeah, we don't really do those kinds of things, but there they had a lot of time to do it. In emergency departments, we don't have a lot of time to do it. So there's lots of examples where they do this in elective surgery in pediatric hospitals. EMLA was the thing we used in the beginning, and the only reason to talk at all about EMLA was because it worked if you put it on long enough, but we were not willing to it's just not convenient for us. But look at the things on paper number 2 that came when we took the time to numb up kids prior to sticking them. We made their parents much, much happier. We made the parents. Why? Because we made the effort. We took the extra effort to make Johnny have less pain. And even if he whimpers a little bit, you get extra points. You get lots of style points because you made that effort and you took a little much more time. The childs were calmer during the process. The parents assessed the kid's pain as much less, which is the important kinds of things there. And the phlebotomist says it was easier to get the blood after these kids were numbed up. So no matter what process we numb up the skin with in terms of a topical, it tends to get us good miles. So the EMLA papers here, we don't need to go into them specifically because they themselves, EMLA, we don't use that anymore because it didn't work because it took too long. One of the papers I like here is number 5. This is a dramatic paper. They compared EMLA cream left on for 60 minutes with giving these kids 2 minutes of nitrous, 70-30, 70% oxygen, 30% nitrous, 2 minutes. And look at the dramatic difference in the pain scores in these kids. The EMLA was left on 60 minutes, and yet the nitrous kids, visual analog pain scale 4.5, nitrous 20, no, 4.5 with nitrous, 22 with EMLA. 4.5 versus 22 on the pain scale. 80% scored 0 on pain after 2 minutes of nitrous oxide, and had no apparent recollection that an IV was even started. It cost 10 cents a dose, 10 cents a dose. Nobody is going to stir the pot on this in the hospitals about, well, why don't we do this? The dentists use this stuff. Why can't we use it? You know, offer it, make it available. We just don't do it. And we'll talk about why we don't do it in a bit. The next papers talk about better stuff. And there's 2 papers. Where's the Canadians? I think the Canadians left. The row is right there. Oh. Are you the designated representatives? You know, you're going to give the notes to your colleagues now we're in bed? You have something there called amethicane? Yes? Yes, Amitop is the trade name for that. That's 4% tetracaine. This is a gel. You can get it. It's not by prescription. There's a 6-study review of this. This stuff is much better than EMLA. But when you look at it, it's in the UK, Australia, Canada, you know, the British have it, but I don't think it's available in the United States. Does anybody know that? Because I try to look up PDR, not there kind of thing. Have you any experience using this stuff?
Just that the nurses say it causes less vasoconstriction and works faster.
Right, that's what they talk about here. The superior lipid solubility of this cane, plus an affinity for neural tissue, plus vasodilatation. So maybe it makes it even easier to start if you put the rub this some and they vasodilate. But in any case, this stuff was pretty impressive. 60% of the kids treated with this methicaine exhibited 0 pain, and 2% had no sensation of pain at all. So had only some sensations. That's 95% of the kids had either 0 pain or minimal pain whatsoever. So they basically said this stuff was really, really quite good. But I don't think it's available here, but the Canadians ought to be using this routinely kind of thing. And we'll talk about what's available in the U.S. The U.S. has got a decent product. In the U.S., the product that is available over the counter, $48 a tube for 30 grams, used to be called ELA Max, is now, its name has been changed because I guess they had some conflict about the name. The name is now LMX4. LMX4 is over the counter. It's a liposomal 4% lidocaine preparation, and there are papers here that basically conclude that if you put this on for 30 minutes, that you'll get good results in the vast majority of cases. And they've compared it head-to-head with 60 minutes of EMLA, 30 minutes of this. This stuff generally works just fine. Paper number 8 also points out baseline anxiety scores correlated with subsequent pain scores. That's getting back to that thing with the neonates. If the people are real anxious before the process begins, this will be reflected in the pain scores that they're going to show. The most important paper in this section is number 9, a pediatric study of 69 ED patients comparing LMX4 with injected lidocaine. There was no significant difference of note between the 2 groups regarding pain, ease of starting the IV, and overall satisfaction. The satisfaction was a little higher with the cream, but they were not statistically different. So that was a nice paper that basically said you're not really compromising particularly any by using this cream versus this injection if you're willing to give it 30 minutes. This paper also talks about some other mechanisms that people are using now to facilitate local anesthesia to speed it up. And I have a paper where they have a little laser gun. This laser gun, basically, you put it on the skin, makes it a little zap, and it basically, I guess, fries the dead epithelium to allow the topical anesthetic to go in faster. And then there's this other paper that talks about the use of, what is this technique called, iontophoresis, where you have a little device, batteries, 2 electrodes, driving the current between the 2, which makes this stuff go in. This is this paper number 10. 2% lidocaine. They have this little battery device is $400. But look at the pain score differences. Without it, the pain scores are 4. With it, 0.5. So it worked very well, but the key here, it only took 10 minutes. 10 minutes, so you don't want to wait half an hour, 10 minutes if you had this device. But none of us seem to be kind of pushing this to happen. And so there's this whole area of practice where, it's okay, we've been doing it that way. The papers 11 through 14 talk about lidocaine. If we could summarize those papers, we would say lidocaine works. 1%, 2%, I would think you would probably use 2%. If you buffer it, buffering is supposed to be causing less burning when they inject the stuff because the lidocaine pH is low, bring it up to normal, so it's less acidic. So, and it also works faster. One of the theories about buffering in terms of why it's a good thing to do when you're doing wound and numbing, those kinds of things, is it raises the pKa, the association constant, and makes it work much more quickly. So maybe there's 2 reasons why it is less painful. It took that pH, which was low, and raised it neutral, and it works quicker. So the idea there is, and style points, you would use a 27 or 30 gauge needle, and you inject a little bit of this. This paper by Dr. Ong, which is, I think, the first one, 11 there, also talks about a little counter irritation where they would just kind of scratch the skin beside the site where the puncture was going to take place. Found that was really pretty helpful too. Studies of the kids have shown that if you distract the kids, there was a paper there that we just passed where they give the kids a pinwheel to blow. If the kids were blowing a pinwheel, making the thing go around, that distracted them. That was substantially effective in terms of decreasing their perceived pain. This is counter-irritation. This is the gate theory of pain, where you're confusing the brain a little bit about where pain's coming from. Now, this was a venipuncture study. It was not an IV insertion study, so they're not necessarily exactly the same. This paper number 11 is 280 adults, alkalized lidocaine. They tried every permutation of stuff they could. Alkalized lidocaine was the best. When you look at the pain scores, saline, when you compared saline with alkalized lidocaine, saline was 4, alkalized lidocaine 0.7. Dramatic decrease in the amount of unnecessary pain. This is, people have necessary pain. We can't fix this kind of thing without causing some pain. This is all, or largely all, unnecessary pain. And then there's the papers on the buffered lidocaine for kiddies. That's number 12. And bottom line is paper after paper after paper says it works. And I don't think we need to go through each one. The one I also like is number 15. 15 is where they compared EMLA, which had ridiculous 5 minutes, versus ethyl chloride. Ethyl chloride really, really worked well. But they took it away from us because they thought we were going to burn the building down or something like that, because it was in a glass bottle and we squirted it. It was always fun. You'd squirt it at one of your colleagues, when you sneak up and hit them with a shot of ethyl chloride kind of thing. But it's not there anymore. Do you have ethyl chloride? You do? Wait, in the ER? Well, they Joint Commission took it out because they're going to blow up the place. It was like a bomb waiting there, Okay, well, in that case, I will be more incentivized to get it back for us too.
There's also fluoromethane, which is functionally the same but a different chemical. That's okay.
That's not flammable. You're not supposed to smoke when you're doing it, kind of thing. I know. But I did hear that there was something else. So this paper is really impressive. This paper, number 15, this is 160 women where they compared subcutaneous lidocaine, the gold standard, with spraying with ethyl chloride. Look at the differences in the pain scores. 23 versus 1. 23 versus 1. They basically concluded ethyl chloride was essentially as effective as lidocaine because 23 was the control, 1 was lidocaine, 4 was ethyl chloride. 23 versus 4, 23 versus 1, huge difference in the pain things. People who had their IV started had a little less pain for a couple minutes after the IV was started when they had the lidocaine. That was apparently the only advantage. There was a trend to more difficulty starting the IV when they used an injection because maybe the couldn't see the vein as well anymore.
How long does epichloride last, the effects of it?
Well, I've used it on a bunch of other stuff, before they took it away for us. And, you got to go pretty quick. It turns white, little white kind of thing, and you better get it in within the next 30 seconds kind of thing. But this was a very impressive study. It was as good as injecting lidocaine in 160 women. Now, there are a couple of other things that they use there, which I don't think are matter. But ethyl chloride, you shouldn't get any lip from the nurses about ethyl chloride or this other alternative.
So how does ethyl chloride work?
Freezes, it's cold.
How about an ice cube works just as well?
An ice cube. Yeah, I think it would. Plus, it's dripping here, down there, kind of thing. This is high. This is tech. You got to have some tech when you do stuff.
Yeah, I know
What kind of doctor are you going to give me an ice cube, kind of here and there? You mentioned that on the first day. I remember that common sense thing. I do know that ethyl chloride is pretty impressive because it turns makes your hairs white and turns your skin white, kind of thing, real quick, and it's very quick. So the answer here is there's no excuse for them not to use that because it doesn't distort the anatomy, it does work, and you need to take the time to be willing to do it. I think personally, all doctors and nurses should have an organ removed every 6 years. They should be hospitalized and have an organ removed. We have lots of unnecessary organs, Take out an appendix, take out a gallbladder, take out a uterus, you don't need them anymore. And well, when you're done with it, when you're done with it, when you're done with it, you don't need to take it out. Leave the ovaries. What's that? Just take out an unnecessary organ, Take your tonsils out, whatever. So that we can be on the other side of the gown that doesn't cover your tush and the person who doesn't come when you've got pain. And all of those other things that as soon as you've had an experience on the other side, you are so much more attuned to the little things that matter. So periodically, I think every doctor should have, and nurse should have.
There's a lot from one patient to another. When I went to medical school, it paid me to stick a nasogastric tube down and spend every Saturday morning doing gastric aspiration. That's when they were doing the H2 studies, or Jack Welch was doing the...
Well, actually, it's interesting because they have rated the unpleasantness of emergency department procedures. NG tube is at the top.
Yeah, I didn't think it was bad at all. I spent...
Well, you're probably a sword swallower after a couple of weeks of that stuff,
Well, and we ended up by getting a small valve biopsy, and in those days, the tube that went down was about the size of your finger and had a big capsule on the ear. Yeah, that was 40 years ago, though.
But 30 years, I can't talk about 40, I can talk about 30 though. And when I was applying to medical school in Philadelphia, there's a whole bunch of medical schools in Philadelphia, Jefferson, Temple, University of Pennsylvania. So I toured all of these schools. And when I went to Jefferson, they said, yeah, we put the NG tubes down each other and start IVs on each other. That scratched off Jefferson. I went to Temple up on Broad Street. That was enough for me. Thank you very much. But that is rated very high, and actually there's a whole other section that talks about all the things that you can do to make the passing of an NG tube more comfortable for patients. But in any case, these are papers that I think that you should consider. I would just rip this chapter out, give this to the nursing vice president at the hospital and said, I think that we ought to do this. And then when they get this one standard of care kind of thing where, well, if we're going to do it here, we're going to do it there kind of thing. And the fact that you brought it to them, I think it'd be very cool. What other practices can reduce the pain of IV cannulation? Start fewer IVs. A long time ago, I read a study in England. We start 10 times more IVs than they do in England. Now, I don't know who's right, but I think it's probably the answer somewhere in the middle. So we start an IV. Whenever you can't think of something better to do, start an IV kind of thing. And pre-hospital care, this is a great study in the next paper. I see all of these people come in by the paramedics when IV started who have absolutely no indication for an IV. And because there's this resistance on their part to use a saline lock, they got to put a bag of water up. And so we get the people with pulmonary edema, got a bag of water up in here, we got pulmonary edema, we got Lasix going in one end, bag of water going in the other end here. It's high science. So the idea is, look at this study here. When the paramedics were allowed to use their discretion on who would get an IV, 56% of the patients got an IV, 56% of the patients. When they objectively assessed whether that person needed an IV by what actually transpired in the emergency department, did they start one there, those kinds of things, did they get any IV meds? A third of the patients who had an IV started in the field did not need one. 1 out of 40 people who did not have an IV started needed one. When a paramedic student was around, the IV excess start rate was 40% higher. Hey, let's give it a try. Come on. I always wanted to start an IV, let's go kind of thing. That was one thing. And the other thing is in the hospital, number 19 is about idle IVs. 42% of people in this hospital study had IVs running in patients for 2 days or more who got no therapeutic value at them. They weren't getting drugs in them, they weren't getting fluids in them. There was just a keep open for 2 days or more, and they were able to show through a little educational process that they were able to decrease that substantially. 20 to 23 talk about using sugar to decrease the pain of things in very young children, neonates, and the rest. And all these people say the same thing. We don't know why this works, but it works. They're talking about 25% sucrose. I don't know what 25% sucrose is. I guess it's sugary stuff. Sugary, you get the bowl of sugar, you mix it with some water, and give a little Johnny or Mary to suck on this and drink this 2 minutes before their painful procedure. And these papers say it does make a difference. It does make a difference. Here's a paper number 22. They point out that kids get up to 20 immunizations by the age of 2 years old. They gave these kids 10 mLs of 25% sugar 2 minutes before the injections. They gave them a pacifier and allowed parents hold the kid. They compared that with kids who did not get any sugar. They laid them on the gurney and did not give them a pacifier. And then they videoed them in terms of, well, what are they? And they basically showed that the kids cried substantially longer when they were treated without being held, pacifier, pre-treatment with sugar. Parents preferred it. On a scale of 0 to 100, parents said 97 in terms of we love it, holding, sugar, pacifier, versus 44 when the kid was laid on the table, here's your shot. 44 versus 97 out of 100. Now, that's for the pediatricians when they're going to give their immunizations to kind of make it clear that you want to make this process as painless as possible for Johnny and make really happy parents.
I think they found that blowing bubbles afterwards just as well.
Blowing bubbles?
Reduces the length of cry. You blow the bubbles immediately after, all into the bubbles.
We need to see a randomized, double-blind trial on that. Thank you. So they all talk about sugar, all four of them. All four of them were positive studies about reducing the pain for procedures in very young children. So I think, where are we here? I think that's enough of that. Tips for starting IV. Oh, here's the paper I like, 24. I don't think this paper is out of date, even though it's old, because if you look at our behavior is consistent with what these anesthetists survey showed. So they surveyed 255 British anesthetists, and 81% of them responded, and 70% claimed to be aware of the literature supporting the use of local anesthesia in association with IV starts. So most of them were. 43% said they altered their practice as a result of this knowledge and literature that they had presented. And as a result of this, they were more likely to use anesthesia for starting IVs. They used it 70% of the time, whereas those who weren't familiar used it 40% of the time. So there was a difference, so they claim. But here's the hooker. Of the doctors who claimed to be aware of the medical literature supporting the use of local anesthesia in association with IV starts, of which I've just given you a sample. I haven't given you a world's literature, but it's clear that the data is pretty compelling, and that the difference in pain scores are substantial. You will perceive a difference in pain when the pain scores are something in the neighborhood of 15 less on a 100 millimeter scale. So if you got pain at 40 and now you're pain at 25, that is a clinically perceptible difference. These scores were saying pain at 40 now is pain at 10. So it's obviously going to be perceived as a difference. These doctors, these anesthetists said, why don't you use it? We don't use it because cannulation isn't painful, so why use it if it's not painful? That was their rationale. Yes, I read it, but since I don't believe it's painful, I don't think I need to use it. This is all about their taking. And they look at the amount of time it takes more. It takes 4 minutes more on average to give a little shot or to put these things on. 6 minutes versus 10 minutes to do these procedures. Papers 25 and 26 say, here's a couple of hints about starting IVs, particularly in kids, where you can place nitroglycerin ointment, rub it on the dorsum of their hands. Anybody do that? Anybody know about that? These papers, 25 and 26, both say, and it doesn't cause any hemodynamic. You think, geez, I'm going to put nitroglycerin on the skin of a kid. Maybe it'll vasodilate their blood vessels or cause coronary artery something or other. 8 of these kids were having cardiac caths, and so they were able to determine whether there was any hemodynamic changes from 15 minutes of nitroglycerin on the dorsum of their hand, wipe it off, start the IV kind of thing. There was no evidence of any hemodynamic consequences from 10 minutes or 15 minutes of nitroglycerin on these kids, 8 of whom had cardiac caths, so they were able to measure pressures and all that, those kinds of things. There's an adult study, and they also mentioned topical ice here. Topical ice is mentioned in 25. Addition of topical ice after nitroglycerin ointment resulted in even larger vein diameters. 25 is what we call a DOE, a disease-oriented outcome. What they found in this study is that you made the veins bigger. They didn't do a study of how many IVs we were able to get in more successfully. They just said when you put nitroglycerin on the top of the kid's hand, the veins became bigger. They became 62% bigger in terms of their diameter. That's a disease-oriented because it doesn't really tell us about any kind of outcomes that reflect patients. 26 is a patient-oriented evidence study. It's a poem. Doctor?
They said these were kids who were going in for a procedure. Maybe ostensibly relatively well or stable kids. That doesn't address the kid that's barely compensating, who's dehydrated or possibly septic, who you're now having trouble getting an IV in, and now you may make them decompensate by giving this nitrate that's going to be absorbed systemically.
That may be true. That may be true. I can't say that I know that wouldn't be the case. But when you read this paper, basically it talks about what they perceive to be the safety of this technique. And the reason we're doing it is because we can't find an IV site to begin with. And our choices are, and those kids that you're talking about, put an NG tube down and try to rehydrate them that way, or do an intraosseous line, or something worse. So the fact of the matter is that it would probably be good to know whether we're going to compromise a dehydrated kid. But if you can't find an IV site, this is a suggestion. And there's another one that's coming up in a second. And the idea of putting ice on, vasodilator, you put your hand in a bucket of ice, kind of thing. Your hand comes out red and swollen, and your rings are tight. Ice causes capillary leak and vasodilatation after you take it out. We used to ice up things to try to decrease swelling and that kind of stuff. The fact is, ice increases swelling because you all know for a fact, you're at the picnic and you're looking for the Heineken, which is at the bottom, and all the Paps is at the top. So you got your hand in there kind of thing, and he comes out and it's red and swollen. So that was one point, and you may have a good point there that maybe it's not safe to do in other kinds of kids. And then the last paper, which was in this section is 27, it says, put something warm on the limb, the hand, and the forearm, and it will make the blood vessels dilate. They use a commercial product here, a warming mitt, but you can easily get a hot towel and wring it out and put it on Johnny's arm and forearm kind of here. And look what happened. When they took about vein scores in terms of favorable sizes of the veins, 30% without, 70% with, better first attempt cannulation rate, 94% when they did it, 75% 72% when they didn't. Faster IV starts, 36 seconds versus 62 seconds, just by putting something hot on the extremity causing local vasodilatation was a clue. And then in a situation like that, you're certainly not, as soon as it's off, it's done kind of thing, would be a safer thing to do. So these are tricks, because otherwise it's, doctor, can you do a central line? Oh, geez, and this little kitty? No, thank you very much. Let's try the hot towel kind of thing. And then the last section here is 4 papers, 28 through 31, that go back as far as 1995 that all conclude that you'll get a safer, faster, more reliable stick with ultrasound-guided central lines rather than landmark-guided central lines. We all were taught landmark-guided central lines. But, things evolve, and the fact of the matter is that this is better. And if when you have your central line started, you would prefer this. And the radiologist can help you if you're not. There are some of us who are older in this who, I don't know ultrasound. And the younger doctors, it's required that they come out knowing ultrasound. So there's clearly an evolution here. But during the day, if you could, you ought to get the radiologist to do this rather than doing it because, we can't find any IV sites peripherally in grandma. It's not a commando situation. Why would you take the risk of pneumothorax missing, hitting the carotid artery, when these papers compellingly say that this is a safer and, in fact, more effective way to do it? All four of them. So I would go back and ask that you make a copy of this chapter, give it to the vice president for nursing and say, why can't we do this? Why can't we do this? I can tell you at our hospital, go ahead.
Well, that was going to be my question. At your hospital, is it standard that to use full-time anesthetic for IV starts?
It is the standard. We have a policy that says it. However, when I'm not there, they ignore it. You have to have a person who's the driver of this. It has to have somebody with some passion about this to say, this is unnecessary discomfort that we're causing. We can fix it. The literature's compelling. You read it. You embrace it. And in fact, let's start an 18 gauge on you and see what you think. On the intern vein here, this one here. Let's do that and see what you think. And let's do the before and after. This is something where my concern about this is that the literature is straightforward. It doesn't cost very much. It's easy to do. It doesn't require a high skill set. Will take a minute or two more. And the fact of the matter is that we choose to turn our back on it. They're going to have enough painful things going on at their visits to the hospital without this. And we could do it with just a small incremental effort. And most of us are kind of particularly sensitive to children and crying and their needs, et cetera, slapping this stuff down on their arms when they come in. And I think this kid's going to need probably some blood work, et cetera. The nurses might say that. Let them put this stuff down in advance, like they do when they do elective surgery kind of thing. If you don't use it, great. Take it, just wipe it off. If you use it, everybody will like it better, except the nurses. The nurses have this callousness to this, which must be stopped. And they won't stop it on their own. You have to drive it. Members of the medical staff have to drive this.
How long you have to wait before you put the lidocaine?
Oh, it's immediate. It's immediate.
And you just use like 5 cc?
Oh, no, this is 0.2 of a cc. They use a TB syringe. The papers say how specifically. It's a TB syringe. The size of the needle matters. 27 or 30. 30s cost the same price as 27s. You just have to generally special order them because you're going to be the only people in the building to use 30 gauge needles, but we use them all the time for anesthetizing wounds. 30 gauge needle, coming through, 25 gauge, it's like a piece of wire, it bends. 25 needle is rigid. Big difference between 25 and 30. So the smaller the needle, and there's lots of studies in the wound management sections that talk about the smaller the needle, the slower that you inject in alkalization, room temperature, all of those things matter. So I would just ask that you consider this. You might think that this is kind of wimpy stuff. You might be with the anesthesiologists who agree, don't think it hurts, but having had my own surgeries and having watched other people do it and having had certain departments routinely do it while other people don't do it, it doesn't seem like it doesn't seem to be the way to go.
We implemented it in our hospital, actually hospital-wide, and the nurses, I know if I'm not there, that's exactly what they'll say is, I'm not doing it.
Well, the reason, what has to happen is it has to be written. This is the policy here. You have violated the policy. It's not your discretion to violate the policy. You can violate the policy when this person's life is on the line. We got a commando IV, got to be getting in the next 30 seconds. It's got to be in. But 99.9% of our IVs aren't like that. And the fact of the matter is that the nurses who are supposed to be the ones who are into this kind of thing about, comfort measures and those kinds of things, they should have embraced this. They should be driving this. We shouldn't be driving this. This is their business. But the fact of the matter is they don't. And what your experience is what my experience is. And they have the belief, well, it may be hard to start the IV. Frankly, to tell you the truth, it may be a tad harder to start, a tad. These papers don't say that. In fact, there's a paper here, and there's a kid's paper here, which I inadvertently skipped over, when they showed it didn't really take any more IV sticks to get a kid than it did before in an experienced person.
Well, I think I actually changed some people's minds, because that's what I had was like a 13-year-old kid, and everyone's like, oh, you're just a wuss. They tried 8 times on this poor kid, and they finally came to me and said, I can't get the IV. Walked in, just a little bit of lidocaine, first shot, boom. And I said, that's the reason you need lidocaine. I mean, it's just because it took away everything for that kid. Once the little burn went away, his whole apprehension by the time they were on start number 4.
Can you imagine what his parents are thinking about the competence of the staff in the process? So the idea here is, well, I'm sorry we missed. You've all seen that. It happens all the time. To know that the next one's going to be started without pain, because they're afraid, oh, Jesus, now I got another one to go through where they're trying to put this umbrella on my forearm kind of thing. It's unnecessary. It is totally unnecessary. So I would like to make you zealots in this regard.
Any studies looking at LET compared to EMLA?
No. No, all of those studies are wounds where they're putting it in the cotton ball in the wound kind of thing for local anesthesia. I mean, and frankly, we still use tack kind of stuff for the, kids with the ditzels on the forehead kind of thing, so you don't have to inject them. They put it on there, walk away, come back 20 minutes later, it's all white around it, that from the vasoconstriction. And the parents appreciate the fact that even if you have to give supplemental, they have appreciated the fact that you have made the effort to make Johnny's experience as positive as possible. And frankly, you would want this on your family members too. So when that standard comes up, well, what would you like? The answer is, if you've ever had this, the answer is, why not? Why not? And yet we're doing it all the time. So this was an attempt to kind of make the case so that you can go back there and say, why don't we do this? Why don't we do this? This is a marker. This is a marker, I think, of people's willingness to go a little extra step to make patients' experience a little bit more positive.